I am Dr. Harvinder Singh. Welcome to Psychiatry Education Forum Academy's updates. So we have a new update from FDA. FDA has just approved the first non-dopaminergic medication for schizophrenia, and the medicine is called Cobenfy. I hope I'm saying it right. The major name is combination of xanomeline and trospium chloride. And this is what I will discuss today, and I will try to be fast. But before I go into that, friends, I posted, I believe in May of this year, 2024, when JAMA Psychiatry published this emergent 3 trial results for this medicine. It was called CAR-XT at that time. Looks like FDA has used that data from Emergent 1 trial, Emergent 2 trial, Emergent 3 trials. Emergent 3 trial was 5-week study. If you want to watch more results of that, please watch that video. Now, before I go into that, I really want to emphasize that I have no disclosures. I have no financial tie with this pharmaceutical company or with any pharmaceutical company for that matters. This is for educational purposes only, and this is what we do at Psychiatry Education Forum. We only post clinically relevant topics that will help you, that will help me, mainly for busy clinical professionals. And I will discuss this medicine in terms of mechanism of action, how to dose, warnings, precautions, contraindication, and drug interactions. Now, friends, we all know that most of the dopamine antagonists, most of the antipsychotics are dopamine antagonists, right? The studies, or theoretically speaking, we know a medicine should occupy certain percentage of dopamine 2 receptor blocking to show some effect. The more blocking causes more side effects ranging from EPS to tardive dyskinesia and many more. But you know, the gold standard antipsychotic, clozapine, has the least dopamine action. So that is likely the reason why the research went into non-dopaminergic area, and now we have the first medicine that works on that. So let's start with that. How does this medicine work? So we know that this is a combination of 2 medicines combined in 1 capsule. It's xanomeline combined with trospium chloride. So this is the major component, friends, xanomeline. So how xanomeline work is, it's an agonist of muscarinic cholinergic receptor, not antagonist, agonist. Be mindful of that. We have muscarinic cholinergic receptor, we have nicotinic cholinergic receptor, but here we are focusing on muscarinic receptors only, friends. Please remember that. And this medicine is very selective for M1 and M4 muscarinic cholinergic receptor, which is known to be responsible for the therapeutic benefit in schizophrenia. Now, it has no direct impact on dopamine receptors, and it's mainly the central action on muscarinic cholinergic receptor which is required for the benefit, friends. Now, but you know this medicine is not selective for central action. It also stimulates the peripheral muscarinic cholinergic receptors, which will do these symptoms. It will activate the GI system, nausea, vomiting, diarrhea. It will cause more sweating. It will cause hypersalivation. So what to do? That is why we have this another combination here in this capsule, trospium chloride. So trospium is a pan-muscarinic receptor antagonist. But then you will be wondering, well, if we have an antagonist, that may totally impact the agonism and xanomeline may lose efficacy. Well, it's not. The reason is this. Trospium is mainly peripherally acting because it never reaches a detectable level in CSF because it is highly polar tertiary amine, which prevents it from crossing that barrier, and thereby it won't show up much in the central action. But friends, be mindful. It's this action on the cholinergic area which you will see like both of these actions are the reason for side effect profile of this medicine also, which I will talk in few minutes. So this is a basic action, basic mechanism, how this medicine is different from most of our other antipsychotics for schizophrenia. Now, the most important question you will ask me, how can I use this in my daily clinical practice? So let's understand how to dose this medication, friend. But before you dose, there are two things you need to do before dosing. You need to check these two things. The number one thing is you need to check liver enzymes with bilirubin. So you need to do hepatic function panel, liver function test. That will check liver enzymes, bilirubin level. And I'll tell you why that is important in a few minutes. The second thing is you need to do baseline heart rate. And you can always monitor these liver enzymes, bilirubin, and heart rate periodically during the treatment. So you have done both of these, and they're normal or no concern noted. Now you will start with the dosing of this medicine. The starting dose of this medicine is, it's a capsule that contains xanomeline plus trospium. It's a twice daily dosing, friend. You start with twice daily dosing. Like we have ziprasidone, right? You start with twice daily dosing. Same way you start with the morning and evening. The starting dose is a capsule that contains 50 milligram of xanomeline and 20 milligram of trospium. The interesting thing is you need to be very mindful of when patient is taking food around this pill, because food impacts the pharmacokinetics of this medication. It has to be taken 1 hour before meal, but if a patient has taken the meal, they should wait for at least 2 hours. So 1 hour before meal or 2 hour after meal. This is very important recommendation. So this is the starting dose. You do this dose for 2 days. And after 2 days, you go to 100 capsule that contains 100 milligram of xanomeline. So you go from 50 to 100. But you will stay on the same dosing of trospium, 20-20. Again, twice daily with the same caution with the food. And then in 5 days, if response is not seen, you can go to the max dose of this capsule that will have more xanomeline, 125, and more trospium, 30 milligram. This is the max dose, friends. But for geriatric population, the max dose is this, 120. Now, this is how you dose it. The most important question after this is, what are the contraindications? What are the caution? What to keep an eye on? What symptoms to check for? And what to do? I have combined everything of that in one section to save time for everyone. Now, the most important contraindication is patient with hepatic impairment, mainly with moderate hepatic impairment or severe hepatic impairment. But even with mild hepatic impairment, it's not recommended. So be mindful, friends. Moderate and severe is contraindication. Mild is caution, so you mostly don't recommend it. So I will say avoid with any hepatic impairment. Keep it simple. Or patient with active biliary disease like symptomatic gallstones, because they found in these trials, patients who had those, the bilirubin and everything went really high, which could be threatening, life-threatening for some people. So you discontinue with early signs of liver injury, which can show up as jaundice, which can show up as pruritus, or when you check the levels, the alanine aminotransferase, if it raises 5 times of the limit or 5 times of the baseline value. That's why you need to do a baseline liver enzyme testing in these patients. So when you're monitoring, when you're doing follow-up with your patient, you need to monitor for these symptoms like dyspepsia, nausea, vomiting, upper abdominal pain. This can all point towards hepatic or biliary involvement. And then accordingly, you should assess for gallbladder issues, biliary disorders, or pancreatitis in these patients. So that is the contraindication number 1, hepatic impairment. Contraindication number 2 is patient with active urinary retention. And who are the patients at risk factors for this? So the risk factors that can increase the risk of urinary retention is geriatric patients, bladder outlet obstruction, patient with incomplete bladder emptying like benign prostatic hypertrophy or diabetic cystopathy, or I will say patients who are on other anticholinergics, right? That can also be an additive risk factors to cause urinary retention. So it's not recommended in patients with moderate or severe renal impairment. It's not a contraindication, but it's not recommended there. So be mindful, hepatic and renal and bladder. Those are the areas you need to keep an eye on. But with the urinary retention aspect, you need to monitor for urinary hesitancy. You need to ask these questions. Patients with weak stream after starting this, or even before starting this. Patients with incomplete bladder emptying, dysuria. Now, all these increases the risk of UTI. So they say females are more at risk of UTI, but as sex, male are more at risk factor. And so you always do three things. First, either you reduce the dose, discontinue the dose, or I should say refer to urological evaluation before starting if the risk factors are high. So that's the contraindication number 2. Third contraindication is patient with gastric retention. So you know it, the anticholinergic impact, doing the gastrointestinal hypomotility, just like how clozapine does. So you need to be cautious. And the caution increases in patients who have ulcerative colitis, intestinal atony, or myasthenia gravis. But look at all the other risk factors. The same way, so we have a chapter on that clozapine adverse event management, right? Look at that chapter, please. Look at all the risk factors. I will say keep an eye on all those risk factors with this medication as well. The fourth is patients with untreated narrow angle glaucoma, because the pupillary dilation due to anticholinergic impact can trigger the crises. So these are the 4 contraindication, friends, that we need to keep an eye on before even starting this medication. The most common adverse reaction, what did the study found? I have discussed this in detail in when I discussed the Emergent-3 trial that was published in JAMA Psychiatry this year. But most common adverse reactions are defined as when a medicine is, when patients on this medicine, at least 5% of those patients are having these, and it's at least twice that of seen in placebo. That's what most common adverse reactions are classified as. The most common were the GI one, like nausea, dyspepsia, diarrhea, vomiting, constipation. Followed by, we have hypertension and dizziness. Now, when I discussed the Emergent-3 trial, the study found they started by 2 weeks, but they never reached a severe range that needed discontinuation, but most of them got better with time. So it looks like it may be a time-limited side effect too, but we don't know yet with certainty. And that is what the Emergent-3 study found. Now, these slides are actually from that Emergent-3 study that I discussed. So they actually looked at a few things with these side effects. Like these commonly reported cholinergic side effects were all mild to moderate in intensity. They mostly began within 2 weeks of treatment, and they were transient in nature. None of those resulted in medication discontinuation or study discontinuation. So that looks okay. And then the EPS, the most common thing, right? We talk about with our antipsychotic. Did this medicine did EPS? Well, this Emergent-3 trial was a 5-week study. They did not found any meaningful change in those EPS scales by week 5 compared to baseline, which is reassuring. But friends, they're already doing Emergent-4, Emergent-5 trials, which are long-term trials. So I think we should wait for that to see how it pans out. And then weight gain. This is really important. Did this study had any weight gain? So based on the Emergent-3 trials, it was not associated with weight gain. Now to go into more interesting numbers, by week 5, when they compared to baseline, medicine had 1.4 plus minus 3.4 kilogram of weight gain, but this was less than placebo, like 2 plus minus 3. So that's good. Now, they also looked at another factor. Patients or participants who had at least 7% increase in their body weight from baseline. Only 5 in the medicine, but 12 in placebo had that. So overall, the numbers are good for weight. And the last thing is the QTC prolongation. The risk was not found with this because I was worried with the impact on heart rate and blood pressure. This medicine did not have QTC prolongation even at the highest dose of that 125-30 combination. So that's good also. So looks like the major things to keep an eye on with this medicine is the liver, the kidney, bladder, gastric, the glaucoma, and those cholinergic side effects. Now, the last section is drug interaction. I will go very fast on this. There were 4 major drug interaction mentioned here. The number one is if a patient is on strong 2D6 inhibitor, because the xanomeline is broken down by 2D6. So if a patient is on 2D6 inhibitor, it will increase the xanomeline plasma concentration. And our 3 antidepressant, which are strong 2D6 inhibitors, are fluoxetine, paroxetine, and bupropion. The list is long. I have not included that, but I've only chosen few. And same goes for second drug interaction, which is if a patient is on 3A4 substrate, but they have mentioned sensitive 3A4 substrate. I'll tell you why the sensitive is included here. Now the 3A4. Why 3A4 is important? Because xanomeline transiently inhibits 3A4. But here's the thing, it's transient and it inhibits locally in the gut, not systematically. That's why only patients who are on sensitive 3A4 substrate, they are at risk of this drug interaction. The list for 3A4 substrate is very long. I have only included the stronger one based on the available data, but even for that list is very long. So the major one that I found were carbamazepine, omeprazole, oxycodone, but friend, the list is very long. Please look into that. The third drug interaction is mainly the drugs eliminated by active tubular secretion in the kidneys, because that can increase the plasma concentration of trospium. Be mindful, out of these drug interactions, this is the one that impacts trospium more. These two were working on xanomeline. Now, the major drugs are antibiotics like cephalosporin, like diuretics, and quinolones, but the list is long. And the fourth drug interaction is patients on P-glycoprotein substrate. And it's mainly because same thing what we saw with here. Xanomeline can transiently inhibit P-glycoprotein, but mostly locally in gut, not systematically. The medications include like digoxin, hydrocortisone, erythromycin, but list is long. Please look into that. I have not mentioned here, but you can already appreciate if a patient is on other anticholinergic medication, the additive side effects can cause worsening of these symptoms, right? So be mindful of that. So friends, this was my brief overview of this new medicine. I hope this was clinically relevant. I'm actually talking fast so that the video is not long. But I just want to take 1 more minute of your time here. So many of you know we have Psychiatry Education Forum Academy, which is our academy membership. Please go to psychiatryeducationforum.com, learn more about it. But we have a new feature called CME Academy now. You can go to psychiatryeducationforum.com/CME Academy. So here I'm releasing courses with CME credits for those. All these courses are chapters from our academy. Now we are just releasing our second course, which is Guide to Understanding and Managing Schizophrenia. You will get 7.75 CME credits. The first course was on major depressive disorder with 8.5 CME credits. Please go and read more details about the table of content, what CME Academy is, what Psychiatry Education Forum Academy is. But I hope this was relevant, and I will see you all in our next video discussion. Till then, you all take care, and bye for now. Thank you again.